talk on tuberculosis of the liver, that is, hepatic tuberculosis, the silent intruder. I will be discussing an often overlooked but important manifestation of the common disease tuberculosis of the liver, where pulmonary TB is well known. Extrapulmonary TB can affect almost any organ in the body, and the liver is no exception. Hepatic TB, though rare, poses diagnostic and therapeutic challenges, especially in TB endemic countries like India. Epidemiology and relevance. Hepatic TB accounts for 0.3% to 1% of all TB cases. It may occur as a part of miliary TB or disseminated TB, that's a blood-borne TB, or rarely an isolated hepatic involvement. With increasing immunosuppression like HIV, diabetes, steroid, steroid, organ transplantation, and improved imaging modalities, hepatic TB is being recognized more frequently. Pathophysiology. There are three main forms of hepatic TB. First is a diffuse involvement as a part of miliary TB, that is a disseminated TB. The most common it is focal or tuberculoma or abscess, that's a localized lesion, and isolated hepatic TB, which is extremely rare but poses a diagnostic dilemma because it's very difficult to diagnose. Mechanism of spread. Hematogenous dissemination is spreading through blood from pulmonary or gastrointestinal foci through lymphatic spread. It could be a direct extension from the adjacent organ, which is rare. So let's talk about the clinical presentation. Symptoms are often non-specific. Fever, weight loss that is a significant, fatigue, tiredness, right upper quadrant abdominal pain or discomfort, hepatomegaly, which could be soft or firm, occasionally jaundice, especially in biliary involvement. In many cases, liver function test may be normal or mildly elevated, especially alkaline phosphatase, not HGOT, HGPT. Diagnosis. High index of suspicion is needed. Investigations. Ultrasound or CT scan. It shows hypodense lesion, hepatomegaly, or calcified granulomas. Liver biopsy, the gold standard to show caseating granuloma. It's a hallmark of tuberculosis. AFB staining may be positive. PCR or CBNAT useful, useful for detecting MTB DNA. Histopathology, it shows epithelioid granulomas caseous necrosis. Then we'll talk about the differential diagnosis. The differential diagnosis includes lymphoma, hepatic metastasis, pyogenic liver abscess, fungal infection, especially in a immunocompromised. So now let's talk about the treatment. As standard anti-TB therapy ATT for 6 to 12 months, in which HRZD for 2 months followed by HR for 4 months. It depends upon the enzyme level whether hepatocyte drug should be started, and if started, the standard drug like pyrazinamide, rifampicin or INH can be withheld or stopped. Monitoring liver function, as ATT drugs are mostly hepatotoxic. Adjuvant steroid in cases with biliary obstruction or immune constitution syndrome (IRIS). Surgical intervention rarely required, only for the complication like large abscess or rupture. So let's talk about the prognosis and conclusion. With early diagnosis and proper treatment, prognosis is excellent. Delay in diagnosis can lead to complications like abscess, rupture, obstructive jaundice, or hepatic failure. Always consider hepatic TB in a patient with unexplained fever and liver lesion, especially in endemic region. So to conclude, hepatic tuberculosis, though rare, is a critical differential in hepatic space occupying lesion in endemic areas. A multidisciplinary approach, including hepatologist, infectious disease specialist, and radiologist, often lead to early diagnosis and effective treatment. Thank you.